Welcome to this deep dive into head and neck cancer. We're tackling a pretty significant area for your board prep.
Yeah, it really is. It accounts for a noticeable percentage of all cancers diagnosed each year, and sadly, cancer deaths too.
And the main type we're usually dealing with is squamous cell carcinoma, right?
That's the predominant one, yes.
Yeah.
Squamous cell.
A key thing to hammer home right at the start, I think, is that link between alcohol and tobacco.
Oh, absolutely. It's not just additive, it's synergistic.
Yeah.
The risk jumps way up when you combine them.
Huge increase. And there are other causes too, aren't there? We should probably mention those.
Definitely. Things like beetle nut chewing, smoked fish consumption,
Yeah.
exposure to wood dust that's particularly linked to nasopharyngeal cancer.
And HPV, of course. Increasingly important, especially in the oropharynx.
Very true. HPV status is critical now.
So, clinically, what should you be looking out for? What are the red flags?
Well, a whole range, really. A sore throat that just won't go away, ear pain, otalgia, maybe hoarseness.
Nosebleeds, difficulty breathing through the nose.
Exactly. Epistaxis, nasal obstruction. Problems with swallowing, so dysphagia or odynophagia, which is painful swallowing.
Shortness of breath can happen too, and those more general symptoms.
Like unexplained weight loss, fatigue,
Yeah.
and, crucially, a painless neck mass. That's a classic sign.
Can't ignore that. Cranial nerve issues, facial pain, or numbness too.
Yes, all possible presenting symptoms.
Okay, so our mission today is pretty clear. Boil down the essential knowledge on head and neck cancer staging and management that you need for your exams.
Exactly. Let's focus on the high-yield stuff, starting with the exam. It has to be thorough.
Right. Head and neck exam, what does that really involve?
You've got to check the cranial nerves systematically, look closely at the ear canal, the scalp.
And then the oral cavity and larynx.
You have a detailed oral exam.
Yeah.
And for the larynx, you'll use either an indirect mirror or, more commonly now, a flexible fiber optic scope.
Get a direct look.
Essential. And an interesting point, sometimes those deep lobe parotid tumors, or ones in the parapharyngeal space,
Yeah.
you can actually feel them as a swelling inside the mouth during the oral exam. It's quite surprising when you find it.
Good clinical pearl. And basic labs.
Standard stuff initially, full blood count, electrolytes, liver function tests. Get a baseline.
Okay, moving on to imaging. This is obviously vital.
Absolutely critical. Usually start with a chest x-ray looking for METs or a second primary.
Then CT.
CT of the neck and chest, definitely, with contrast. That's your workhorse.
And what are we looking for in the nodes on CT?
Key radiographic signs for metastasis are usually nodes bigger than a centimeter, or nodes showing central necrosis that sort of break down in the middle.
Got it. When would you reach for an MRI instead of, or as well as, CT?
MRI gives better soft tissue detail, so it's particularly useful for certain locations. Think nasopharynx, paranasal sinuses,
Skull base?
skull base, definitely. Also infratemporal fossa, carotid gland tumors, parapharyngeal space, areas where distinguishing tumor from muscle or nerve is key.
Makes sense. MPT scans, where do they fit in?
Key EAT is really valuable for looking for distant metastatic disease, also for checking for recurrence after treatment.
And in that tricky situation, the unknown primary.
Exactly. If you've got a cancerous node in the neck, but can't find where it started, PE can help identify suspicious areas or confirm there's no obvious primary elsewhere. It helps target further investigation.
Which brings us to getting tissue, FNA.
Fine needle aspiration, yes. If you have a neck mass, particularly in a smoker over 40, and it's been there for more than, say, 2 weeks,
You need a diagnosis.
you need tissue. FNA is usually the first step. It's minimally invasive.
Important point, though, avoid just cutting the lump out, right? If you suspect SCC.
Generally, yes. Open excisional biopsy of a neck node suspected to be SCC metastasis is frowned upon. There's a risk of tumor seeding into the skin and soft tissues, potentially making curative treatment harder.
Okay. Exception for lymphoma.
Right. If the FNA suggests lymphoma, or if it's non-diagnostic and suspicion is high, then you do need an excisional biopsy. You need the architecture of the node, and importantly, you need fresh tissue for flow cytometry.
Makes sense. And what about looking directly at the potential primary sites,
That's where panendoscopy comes in, sometimes called triple endoscopy,
which involves?
direct laryngoscopy, looking closely at the larynx, rigid esophagoscopy for the esophagus, and bronchoscopy for the airways. All done under general anesthetic, usually with biopsies taken from any suspicious areas.
Okay. And back to that unknown primary problem for a second. If Pete doesn't show anything obvious,
Yeah, it's a challenge. Management can be controversial, but strategies often include PT-directed biopsies if there are subtle hotspots.
Or even blind biopsies?
Sometimes, yes, biopsies of common sites like the nasopharynx, especially Fios and Mueller's foci, those recesses and the base of the tongue. Bilateral tonsillectomy is also frequently done, as the tonsils can harbor occult primaries.
Right, trying to cover the likely bases.
Exactly.
Okay, let's shift gears to neck anatomy. The levels. Super important for staging and treatment planning.
Absolutely fundamental. And the first thing to say is, these neck levels are not the same as the trauma zones of the neck.
Crucial distinction, don't mix them up in the exam.
Please don't. Okay, so level 1, that's up under the chin and jaw.
Submental and submandibular triangles.
Precisely. Divided into ia, which is submental between the anterior bellies of digastric, and ib, submandibular, lateral to that, bounded by the mandible superiorly and hyoid inferiorly, contains the submandibular gland too.
Got it, level 2.
Level 2 is the upper jugular group, runs from the skull base down to the hyoid bone, or the carotid bifurcation, bounded posteriorly by the SCM muscle, anteriorly by the stylohyoid.
And it's split, isn't it? II and ida.
Yes, the spinal accessory nerve, cranial nerve 11, runs through level 2 and divides it. IA is anterior to the nerve, IAB is posterior.
Okay, level 3.
Middle jugular nodes. Below level 2, so from the hyoid down to the cricothyroid notch, or where the omohyoid muscle crosses the carotid sheath. Again, bounded by SCM posteriorly and the sternohyoid muscle anteriorly.
Very straightforward boundaries there. Level 4.
Lower jugular group. Below level 3 down to the clavicle. Same muscular boundaries anteriorly and posteriorly.
And 4 also has sublevels, though less commonly used.
Well, sometimes mentioned. The SIVA deep to the sternal head, IV deep to the clavicular head of the SCM. But level 4 as a whole, from cricoidomohyoid down to clavicle, is the main thing.
Right. Level V, that's the posterior triangle.
Correct. Behind the SCM, in front of the trapezius muscle, above the clavicle.
Also divided.
Yes, VA is superior,
Yeah.
above a horizontal line at the level of the cricoid cartilage, and VED is inferior below that line. Sometimes divided along the path of the spinal accessory nerve or transverse cervical artery.
Yeah.
The omohyoid's inferior belly is often used as the divider clinically.
Okay. Nearly there. Level 6.
Anterior compartment. This is midline between the carotid sheaths laterally from the hyoid bone down to the suprasternal notch. Contains thyroid, parathyroids, larynx, trachea, esophagus nodes.
Pretracheal paratracheal nodes.
Exactly. And finally, level 7.
The superior mediastinum.
Yep, below the suprasternal notch, down to the level of the aortic arch, sitting between the carotid arteries. Upper mediastinal nodes.
Okay, that's a lot of anatomy, but absolutely key for describing node involvement and planning dissection.
Couldn't agree more. They have those levels.
So let's talk staging, the AJCC system.
The standard, American Joint Committee on Cancer. It divides head and neck cancers based on their primary site.
Like lip and oral cavity, pharynx, larynx.
Right. Pharynx is then split into nasopharynx or pharynx hypopharynx. Then you have paranasal sinuses, major salivary glands, thyroid, and even mucosal melanoma has its own chapter.
And within those broad categories, specific subsites are defined.
Yes, like mucosal lip, buccal mucosa for oral cavity, supraglottis, glottis, subglottis for larynx, parotid, submandibular for salivary. Lots of detail.
And the core of the staging is TNM.
Tumor, nodes, metastasis. T describes the primary tumor size and extent of invasion. N describes regional lymph node involvement. M describes distant metastasis.
And you mentioned earlier, the overall stage number isn't always the most useful thing.
Clinically, the specific T and M combination often tells you more. For example, a T1N1M0 might have the same overall stage group as a T3N0M0 in some systems, but their biology and treatment approach could be quite different.
Makes sense. We also see prefixes sometimes, like P and C.
Right. C stands for clinical staging based on exam, imaging, endoscopy before definitive treatment. P is pathologic staging based on findings after surgical resection.
And pathologic stage trumps clinical if available.
Yes, PT&M supersedes CT&M if surgery is performed. There are other symbols too, like M for multiple synchronous primaries, Y for staging after neoadjuvant therapy, R for recurrence, A for autopsy staging.
Important details. What about other biologic factors mentioned in path reports?
Things like paraneural invasion, PNI, cancer tracking along nerves, or perovascular invasion. These indicate more aggressive behavior.
And extracapsular spread,
A
ECS.
huge prognostic factor. If cancer cells break out of the lymph node capsule into surrounding tissue, it's a strong indicator for needing adjuvant radiation, often chemotherapy too. Really worsens the prognosis.
But tumor grade isn't that important for prognosis and SCC.
Generally, no. Unlike in some other cancers, histologic grade well-differentiated, moderately, poorly, doesn't have major independent prognostic value in most head and neck squamous cell carcinomas.
Good to know. And once staged, always staged.
Correct. You don't restage a patient if they develop metastasis later on.
Hmm.
They retain their initial stage, and the recurrence or metastasis is documented separately.
Okay, let's dive into the T's staging specifics a bit. Lip and oral cavity.
TX means cannot be assessed. T0, no evidence, tis carcinoma in situ. Then T1 is 2 centimeters or less. T2 is more than 2 centimeters, but not more than 4 centimeters. T3 is more than 4 centimeters.
Size base for T1, T3, T4 gets more complex.
Right. P4 is divided into T4A, moderately advanced local disease, and T4B, very advanced. For oral cavity, T4A involves invasion into adjacent structures like cortical bone of the mandible or maxilla, deep tongue muscles, maxillary sinus, or skin of the face.
And T4B.
T4B is invasion into the masticator space, pterygoid plates or skull base, or encasement of the internal carotid artery. Basically, unresectable disease.
Okay. Nasopharynx. Different criteria there.
Yes, not based on size. T1 is confined to the nasopharynx or extends to oropharynx nasal cavity. T2 extends into the parapharyngeal space.
T3.
T3 involves bony structures of the skull base, paranasal sinuses, etc. T4 is intracranial extension, cranial nerve involvement, or extension to hypopharynx orbit or infratemporal fossa masticator space.
Oropharynx. Again, size and invasion.
Similar pattern. T1 involved 2 centimeters, T2 2 centimeters, but 4 centimeters, T3 4 centimeters, or extension to lingual surface of epiglottis. T4 involves larynx, deep tongue muscles, medial pterygoid, hard palate, or mandible.
And T4B oropharynx.
Lateral pterygoid muscle, pterygoid plates, lateral nasopharynx, skull base, or encasing the carotid artery. Again, very advanced.
Larynx staging is quite detailed, broken down by subsite.
Extremely detailed. Supraglottis, glottis, subglottis each have specific T criteria based on invasion within the larynx, vocal cord mobility, cartilage invasion, and extension outside the larynx. T4A involves thyroid cartilage erosion or invasion beyond the larynx. T4B invades prevertebral space, encases carotid, or involves mediastinal structures. You really need to look up the specifics for each subsite.
Okay, and finally, major salivary glands.
T1 equals 2 centimeters without extraparenchymal extension, EPE. T2 2 centimeters but equals 4 centimeters without EPE. T3 4 centimeters or any size with EPE.
And T4 for salivary.
T4A involves skin, mandible, ear canal, or facial nerve. T4B involves skull base, pterygoid plates, or encases carotid artery.
So a common theme for T4B across many sites is that unresectable invasion of deep structures or carotid encasement.
Exactly. That's the key differentiator for very advanced disease. Understanding T4A versus T4B is critical for treatment planning operability versus primary chemoradiation usually.
Right. Let's move to N regional lymph nodes. You said this has the biggest impact on survival.
By far, nodal metastasis is the single most important prognostic factor in head and neck squamous cell carcinoma.
And the staging system is fairly consistent across sites, except nasopharynx.
Generally, yes. Nasopharyngeal nodal staging is a bit different, often incorporating laterality and level, but for most others, NX nodes cannot be assessed. N0, no regional nodomets.
N1.
Single ipsilateral, same side node, 3 centimeters or less in greatest dimension.
N2 gets subdivided.
Yes. N2A is a single ipsilateral node, more than 3 centimeters, but not more than 6 centimeters.
Sure.
N2B is multiple ipsilateral nodes, none more than 6 centimeters. N2C is bilateral or contralateral nodes, none more than 6 centimeters.
And N3.
Any node metastasis larger than 6 centimeters in greatest dimension.
What about terms like fixed or matted nodes? We don't use those anymore.
They're not part of the formal AJCC-N classification now. Size, number, and laterality are the key criteria. Extracapsular spread, ECS, is noted separately and is prognostically very important, often upstaging the N category or stage group.
Okay. And M distant metastasis.
That's simpler. M0 means no distant metastasis. M1 means distant metastasis is present.
Lungs, liver, bone being common sites.
Exactly.
All right, so that's the staging system. How does this translate into treating the neck?
Well, general principles apply. If the neck is clinically N0, no evidence of involved nodes on exam or imaging.
What are the options?
Depends heavily on the primary tumor site and T stage, and the risk of occult hidden metastases. Options are observation, watchful waiting, elective neck dissection, removing nodes prophylactically, or elective neck irradiation.
And if the neck is clinically positive, N1 or higher?
Then comprehensive treatment of the neck is almost always required. That usually means a therapeutic neck dissection, often combined with adjuvant radiotherapy, or sometimes primary chemoradiation that includes the involved nodal basins.
Let's talk about neck dissection. When is it indicated?
Obvious indication is clinically or radiologically positive nodes, but also for high-risk N0 necks, depending on the primary site.
Other specific indications?
Large or rapidly growing primary tumors, extraglandular extension from a salivary primary,
Yeah.
facial nerve palsy suggesting parotid cancer spread, certain aggressive histologies like SCC, adenoid cystic, high-grade mucoepidermoid, adenocarcinoma, those often warrant elective dissection even if nodes look clear.
Okay. Can you define the different types of neck dissection? Radical first.
Radical neck dissection, RND, is the historical benchmark. It removes all lymph nodes in levels I through V. Critically, it also sacrifices the sternocleidomastoid muscle, SCM, the internal jugular vein, IJV, and the spinal accessory nerve, SCN, CNXY.
Causes significant morbidity. You're right. Shoulder dysfunction, cosmetic changes.
Yes, significant morbidity. That's why modified radical dissections were developed.
What do they preserve?
Modified radical neck dissection, MRND, also removes level IV nodes, but preserves one or more of those three non-lymphatic structures, SCM, IJV, SAN-CN. There are subtypes. Type I preserves SAN, Type 2 preserves SAN and SCM, Type 3 preserves all three. Type 3 is the most common MRND.
So it keeps the function and form better. What about selective neck dissection?
Selective neck dissection, SND, removes only specific nodal levels considered at highest risk for metastasis from a particular primary site, often used for the clinically N0 neck. For example, an oral cavity cancer might typically get a dissection of levels 1, 2, and 3.
Tailored to the expected drainage pattern.
Exactly. Preserves structures and removes only the necessary nodes.
And extended neck dissection.
That just means removing additional lymph node groups beyond levels IV, like level 6, 7, retropharyngeal, or non-lymphatic structures not typically removed in an R&D, like carotid artery, hypoglossal nerve, usually due to direct tumor involvement. It can be combined with a radical or modified approach.
Okay, clear overview of neck dissections. Let's pivot to salivary gland tumors. General approach.
Surgery is almost always the primary treatment for salivary tumors, benign or malignant.
Where do they most commonly occur?
Parotid gland is by far the most common site. Thankfully, most parotid tumors, maybe 80%, are benign.
Then submandibular.
Yes, second most common. Then sublingual and the minor salivary glands scatter throughout the upper aerodigestive tract.
And there's that rule of thumb about malignancy risk.
Right. Generally, the smaller the gland, the higher the likelihood that a tumor within it is malignant. So parotid tumors often benign, minor salivary gland tumors more likely malignant.
Clinical tip? Any mass in front of the ear.
Assume it's parotid origin until proven otherwise. That's the default assumption.
What about salivary tumors in kids? Different patterns.
Somewhat different. Vascular neoplasms are common, especially hemangiomas in the parotid. They often appear early and most involutes spontaneously.
Lymphangiomas.
Less common, present early too, but rarely involute. Might need surgery or sclerosing agents.
Most common solid benign tumor in kids.
Same as adults, actually. Pleomorphic adenoma.
But malignancy rate in solid tumors.
It's higher in children than adults. Roughly 50% of solid pediatric salivary tumors are malignant, and the most common malignant one in kids is mucoepidermoid carcinoma.
Okay. Let's focus on the common adult tumors. Most common benign overall.
Pleomorphic adenoma, also called benign mixed tumor. Classic presentation is a slow-growing, painless, mobile mass, often in the tail of the parotid.
Facial nerve involvement.
Very rare with benign pleomorphic adenoma. If the nerve is involved, suspect malignancy.
You mentioned deep lobe tumors earlier, presenting interorally.
Yes, if they arise in the deep lobe of the parotid, medial to the facial nerve, they can bulge into the parapharyngeal space, causing interoral swelling. Trying to remove these transorally has a higher recurrence risk.
And recurrence is a problem if not fully excised.
Definitely. Simply shelling out or enucleating a pleomorphic adenoma leads to high recurrence rates, often as multiple nodules. Each subsequent surgery carries higher risk to the facial nerve.
Because it doesn't have a true capsule.
It has finger-like projections, so you need a margin. Histology shows epithelial, myoepithelial, and stromal components, hence mixed tumor. For tumors in the superficial lobe, superficial parotidectomy with facial nerve preservation. If it involves the deep lobe, usually a total parotidectomy is needed, again preserving the nerve if possible. They're generally radioresistant.
Okay. Second most common benign.
Warthin's tumor, or papillary cystadenoma lymphomatosum. Strong association with older male smokers.
Key features of Warthin's.
Can be bilateral in about 10% of cases and multicentric within the same gland in another 10%. Classically hot on technetium-99 meter scan due to high mitochondrial content.
Histology.
Characteristic biphasic pattern. Double layer of eosinophilic epithelial cells overlying a lymphoid stroma, often with cystic spaces.
Treatment similar?
Yes, a surgical excision, superficial, or deep periodectomy depending on location with nerve preservation.
All right, let's talk malignant salivary tumors. Most common overall.
Leukoepidermoid carcinoma. That's the most common malignant salivary gland tumor in adults and children.
Comes in different grades.
Yes. Low grade tends to be more cystic, behaves indolently, may have a specific T1119 translocation. High grade is more solid, aggressive, mimics squamous cell carcinoma, and has a poorer prognosis.
Okay. What about adenoid cystic carcinoma, ACC?
ACC is the most common malignant tumor of the submandibular and minor salivary glands. Palate is a frequent intraoral site.
How does it usually present?
Often as a firm, slow-growing mass, but can be asymptomatic for a long time. Pain or nerve involvement can occur later.
Known for any particular behavior?
Yes. Notorious for perineural spread, tracking along nerves, often far beyond the visible tumor. This makes achieving clear margins difficult. Also prone to late distant metastases, especially to the lungs.
But nodal met's less common.
Relatively low rate of nodal metastasis compared to SCC. Locally invasive, though, often with extraglandular extension.
Recurrence pattern.
Late recurrences are common, sometimes 10, 15, even 20 years later. Needs lifelong follow-up, usually including annual chest imaging.
Histology subtypes relate to prognosis.
Yes. Three main patterns. Cribriform, Swiss cheese, generally has the best prognosis. Tubular is often low grade. Solid pattern is associated with high-grade behavior and worse outcomes.
Okay. Can we broadly group malignant salivary tumors by grade?
Sure. Low-grade malignancies include low-grade mucoepidermoid, actinic cell carcinoma. High-grade includes high-grade mucoepidermoid, adenoid cystic, especially solid pattern, SCC arising in a salivary gland, adenocarcinoma, undifferentiated carcinoma.
And malignant mixed tumor.
Also high grade. This is a carcinoma arising in association with a pleomorphic adenoma, carcinoma, ex-pleomorphic adenoma, or arising de novo, very aggressive early metastasis.
Got it. When would you typically add radiotherapy after surgery for salivary malignancy?
There are several key indications for adjuvant radiotherapy you should strongly consider it for.
Go on.
1. High-grade malignancies. 2. If there's residual disease left after surgery, positive margins. 3. Recurrent disease.
4.
Invasion of adjacent structures like bone, nerve, skin, basically definite extraparenchymal extension. 5. Close margins, even if technically negative.
6.
Perineural invasion is a strong indication. And 7. Generally for advanced T-stage tumors, so T3 or T4, parotid cancers.
Those are really important indications to know.
Absolutely critical for exam purposes and clinical practice.
Okay, let's wrap up with some general tips and key takeaways. Any quick pearls?
Well, remember, supraglottic laryngeal cancers have a high rate of occult nodal mets, so you almost always need to treat the neck, either with surgery or radiation.
Good one. What about radiation after neck dissection?
Post-op radiotherapy to the neck should definitely be considered if the path report shows more than one positive node, PN2 or higher, or even with just one positive node, PN1, if it has adverse features like ECS or PNI within the node.
What about sacrificing both IJVs? Survivable.
It increases morbidity, significantly risk of facial swelling, increased intracranial pressure, but yes, it is survivable if necessary. Collateral venous drainage develops.
Surgery after radiation.
Be prepared for higher complication rates. Wound healing issues, fistula formation are more common.
Tracheotomy.
Maintain a low threshold for perioperative tracheotomy, especially with significant resections, bilateral neck dissections, or expected airway swelling. Better safe than sorry.
Planning for flaps.
Crucial. Preoperative communication with the reconstructive team is vital. If a free flap might be needed, you need to know which neck vessels, like facial artery vein, need to be preserved as potential recipients.
Laryngectomy, patients swallowing and speech.
Swallowing can sometimes be improved by adjuncts like pharyngeal plexus neurectomy or cricopharyngeal myotomy done at the time of laryngectomy. Speech rehab involves esophageal speech, or more commonly now, tracheoesophageal puncture, TEP, with a voice prosthesis.
Nutrition.
Consider early placement of a gastrostomy tube, G-tube, for nutritional support, especially if significant dysphagia or weight loss is anticipated during or after treatment.
Alcohol withdrawal.
Big issue in this patient population. Be aggressive with prevention and management of delirium tremens if there's any suspicion of heavy alcohol use. Use CIWA protocol.
Drains and potential complications.
Use high-output suction drains, especially after neck dissection. Be particularly vigilant on the left side for Tilis fistula due to potential thoracic duct injury output. Will look milky.
Early post-op fevers.
A high fever spiking early, maybe day 3 through 5, could signal a pharyngocutaneous fistula, a leak from the pharyngeal repair.
First feed post-op.
Good practice to do the first oral intake, often liquids, with a dye like methylene blue before pulling neck drains. Helps check for both fistula, dye and drain, and aspiration, dye and tract secretions if present.
Great practical tips. So let's recap the absolute key points for board review.
Okay, number 1. Nodal metastasis has the single greatest influence on survival. Manage the neck appropriately.
Number 2, alcohol and tobacco are major synergistic risk factors.
Number 3. Know your neck dissection levels. They are distinct from trauma zones.
Number 4, most common malignant salivary tumor.
Mucoepidermoid carcinoma.
Number 5, most common benign salivary tumor.
Pleomorphic adenoma.
And finally,
Warthin's tumors can be bilateral or multicentric. Remember that association.
excellent summary. This deep dive has, I hope, hit the core knowledge you need for head and neck cancer staging and management for your exams. Really try to connect how the risk factors, the presentation, the detailed staging, and the treatment principles all interlink.
It's all connected.
So a final thought to leave you with. Given we've emphasized just how critical nodal metastasis is for prognosis, what do you think are the most crucial factors or strategies for improving the early detection and effective management of regional neck disease in patients with head and neck cancer? Something to ponder.